proximal part of the nerve, I'm going to use the median nerve. I'm going to fixate that median nerve at the elbow, from the brachial plexus to the elbow, and then I'm going to do like a distal sensitizing maneuver. So we're going to combine either elbow extension, wrist flexion extension, and just tension the nerve from kind of start to end point.
Does everybody remember their evil TTs?
The median nerve, let's go through them. And I can light them up pretty quickly. Okay, shoulder depression, abduction to about 120 degrees. Okay, full lateral rotation, wrist extension, finger extension, full supination. Slowly, and we're about there. There. So if I know there, I'm not going to have him do this in this position. So what I will do is I can come here. And so a tensioner. All I'm doing is tensioning that nerve. Okay, I can add in a different component to it. It's still a tension. You can do distal to proximal, you can do proximal to distal depending on where you feel like that restriction is and how much you like your symptoms of. Okay, sliders I think of as a more active type exercise. So I may have him go through, get into a median nerve position, start off with elbow flexion, wrist extension, and finger extension, and then he's going to go into a combination actively, add in a cervical component to that. So he might start off here, and then as he goes into that, he's just alternating different movements proximally and distally. And instead of just tensioning that nerve, whether it's proximal or distal, he's actually sliding that nerve back and forth. One question you're going to get a lot, and I still get this pretty regularly, is am I stretching the nerve? I don't know of anything out there that's a source that you can stretch a nerve, but it should make sense. Okay, you can. Mr. Sheldon here would know.
Increase the length of the nerve, but you can't apply tension to it.
There you go. What he said. So you are going to have areas of restriction. So for example, someone has a cubital tunnel trauma. Maybe they trip, they fall, they whack their elbow. There's going to be some sort of inflammatory response, some sort of scar tissue. There's some really good evidence to say we could end up with some adverse neural tension, like some myofascial tightness there. Someone has some postural changes. They end up with postural adaptations, myofascial changes. They could have adherent nerve roots. And think about it, that median nerve all the way out to the DIP, okay, and all those little mini branches of it start all the way up at the C5 to T1 nerve roots. So we got to think about it. We want to impact some sort of change in that neural system from really start to finish.
Which one is more aggressive, a tensioner or a slider? So where do you think you want to start with the patient?
And what is a better home exercise program? Slider. Because I'm a lot less likely to light them up. Okay, am I going to give this to them on the first visit when I haven't had a good assessment of how they're going to tolerate it at home? No, this is something that I probably would start to reinforce on a first visit. I probably wouldn't give it as a home program until the second or third visit, until I know what their reaction to a neural tension assessment is. Because I guarantee you send them home prematurely and you light them up really bad, okay, you're going to have a really hard time getting buy-in.
What's a good dosage strategy? Anybody.
It has to be the same thing about muscle energy.
So if you just met this patient, you're on your second visit, and you don't know exactly how well they're going to tolerate nerve glides, just give them 10. Just give them 10 at a time. It's not that big of a deal. Have them do 10 on one side, have them do 10 on the other side. Do that every couple of hours. See how they tolerate that. That's a real nice low dosage. It's not going to push them overboard.
So,
It emphasizes you don't want to do 100 at one time because this is a nervous tissue that you repeatedly move.
Do you see results immediately, or do some, like she was talking about, the tension getting better?
Yes.
So that's how you monitor how you're doing sometimes.
You would notice, the patient would notice an increase in the range of motion with decreased sensations of tension, decreased radicular symptoms, improved range of motion. There's a lot of good research coming out that adding nerve glides to hamstring stretching programs significantly impacts the increase in flexibility in hamstrings versus just a traditional static stretching positions. So a lot of flexibility component is neurally driven. So if you're working on the nerve first time you can extend their elbow, the first time you can extend their leg, and see what degree of extension they have, and that's going to be a marker for progress because they're improving their neural mobility or they're decreasing the amount that they're guarding. Other radicular symptoms here, a lot of times you'll see immediate reduction in pain with nerve glides.
By the way, feature CI, you'll read all that.
What I would add to that is maybe just to simplify it a little bit is you're looking for two factors. You're looking for patient subjective response. Are the symptoms less than what they reported? And then two, is there a measurable change that I can look at objectively? So I like what Jared said as an assessment. I'll use a lot of times that elbow extension or lack of extension as my indicator. If they're at 95 degrees of elbow flexion, when I start to light them up with that ULTT1, and they do a couple rounds of nerve glides, and I can get them out to 45 degrees, and their symptomology is less, I think that's a win. That's signs of forward progress to me, or you get an adverse tension in a pitcher, and they get here with the ulnar nerve, so maybe about 90 degrees of flexion, and then you treat them and they're able to get to 120 degrees of elbow flexion, and their symptoms are less. So look at those little wins as ways to demonstrate progress, not just so you can objectively track it over time, but then you can reinforce patient buy-in.
Absolutely, because patients' nerves are abstract to people. They don't understand that they're, visible, big, tangible structures in our body like you do. They can't picture them, where they travel, and you tell them we're going to do a nerve blood exercise, and they're like, what the heck does that mean? And if you emphasize to them, look, you're getting symptoms right here, I'm going to do some magic on your arm for about 30 seconds, and all of a sudden you're to here. That really drives home the importance of how valuable that exercise can be to them, so you get patient buy-in. Patient buy-in is really important.
That's right. So the other thing that's on the very bottom there is good. So that's the answer. They're asking us your technique. It's really good. Okay, so we're going to do a combined, I'm going to use first just a mobilization for side translations with neural tension and see if by doing those we don't improve his overall flexibility, and then do one with muscle energy and see if we can't utilize kind of that connection. So what's the connection between his cervical vertebrae, cervical paraspinals, and his brachial plexus and median nerve? It's all joint, right? You got cervical nerve roots that are at you have a dural lining, you have the neural foramen, that the spinal nerves exit at each level. So we have a lot of interconnectedness before we ever even start talking about soft tissue overlay of the multifidus, the paraspinals, all those kind of things. So a lot of times, so let's get them into a position where you first start to, should I ask you this? Don't think this is going to get you Okay, so let's back off that a little bit. Okay, come back to about here. Put in full external rotation. Let's just do a couple of glides. So I do this pretty non-specifically. We're C5 to T1. Okay. Okay, so I can be anywhere from C4 down to C7, T1, and I'm just gliding lateral translations, just the same way that you learned. Okay, so that's about a 15–20% improvement. All I did was 20 seconds. Let's do this one. It's 20 seconds of translations, and we saw an immediate improvement. So that could be something too, that as you're helping them work through that exercise, just to do a little bit of cervical translations or some cervical muscle energy.
Are you staying on the same vertebrae the whole time?
Nope, move it up and down. So about there, okay? So for there, usually what I'll do is I'll relieve some of that stress instead of taking about that directly. Okay, I'll do a translation to that side, and then I'll say go ahead and bring your ear to your left shoulder. Okay, hold that for a couple seconds, relax. We'll need that a little bit more. Go ahead, another translation, go ahead again. And relax. I'll bring it back to neutral, let's take that into cheek as well. Okay, so really quick techniques that we can see a demonstrable change. All I did with that is, why did I bring them to lateral flexion to that side? Just to take some of the slack off of that nerve root. So by doing that, I didn't have to change here. I could just look at that immediate effect. And then all I did was translate them to the right and translate them to the left, C4 on C5, and added in a muscle energy track relax for side bending to just see if that neural reset produced any results. And we got a 10%, 15% increase.
Can you show us kind of what a radial one would look like? I'm trying to figure out interaction.
Radial.
I got it.
Okay, so radial is the opposite, right? Median, I'm all starting in flexion, I'm pronated, wrist extension, finger extended, full external rotation, and I'm going into elbow extension. For radial, I'm starting off in slight abduction. I'm internally rotated, I'm elbow extended, I'm forearm pronated, wrist flexion, finger flexion, and then extending the shoulder to about 15 to 20 degrees.
Slide in and out of that, would you just like release the wrist?
You could release the wrist, you could extend the fingers, you could have them do supination, external rotation. I could have them in this position, and just thank you, and then just have them do cervical rotation. And that would be an example of taking it more proximally than distally, and then just see how his symptoms change over time. So we're here, and if I'm going to do this right, there we go. So he's just doing cervical rotation. Put it on the side. Yeah, do it kind of off to the side so you go from C. Go through it again. Depression, elbow extension, internal rotation, forearm pronation, wrist flexion, finger flexion, abduction, extension.
So I have a 4 out of 10 discomfort or tension feeling here, and a 0 out of 10 here. 9 out of 10.
Would you suggest doing the proximal slider on that one versus the releasing tension of the wrist then?
I think you're
Just
safe.
adjusting shape.
Yeah, I think you're safe to always start with proximal to distal, because if you think about the lever arm, the torque that's going to be on that nerve through the whole rotation or the whole motion, it's going to be a lot greater if I'm here and if I'm just having them flex and extend. You know, all of that torque is being dispersed across that entire radial nerve, as opposed to if I'm just here and I just have them start here, it's more your lever arm is just in that arc of rotation. You know, the distance between the nerve root and the start of the plexus, at least in the way I think about it.
Say, be careful. Typically, the most sensitizing component of the ULTT or a nerve flight is going to be scapular depression. So you can really light somebody up. You guys saw that when he really forced his scapular depression on me, I went from a 4 out of 10 sensation to a 9 out of 10 sensation really fast. So be careful with that with your patients. And you can also use scapular depression on and off as one of the components of glide. I would just say, if you think about the plexus, where it goes through, it goes underneath your collarbone, right? On top of your first rib, underneath the acromion and the pec minor. So if that's your thoracic outlet, if you think about depressing the shoulder girdle, the hook of the acromion, the little roof of the acromion and the pec minor, directly pulls down on top of the plexus. So if you have somebody with thoracic outlet syndrome, scapular depression and elevation might be a really key component to improving your neural mobility through the thoracic outlet. But it could also be a really aggressive sensitizer as well.
Questions about that? We practice median